go to your, hopefully stop sharing blogs, and then right now, validation sheets, Skills Lab manual, Careplan info, let's see here. Formula universal diagnosis, skills, diagnosis development. Let's take a look at this. These are all, it should be all in your I don't see it. Where does it? There we go. It's a lot better. So when you go to your clinical site next week, some of you guys are going with myself, some of you guys are going with Professor Chong. Who's the other group going with?
We don't know yet.
You haven't reached out yet?
No.
It might be, it's either gonna be Professor Ross, Lear, I don't know. So they'll reach out to you this week, don't worry. And so then I suggest that you bring this with you. Not suggest, it is a requirement that you take this with you to your clinical site next week, okay? The Careplan is, how can I explain what a Careplan is? This right here is about, well, I can only see 2 pages here, but by the time this is all finished and done with and typed out, it should come out to about 7 to 12 pages, okay? And before you start getting all fussy, I felt a sigh in the room. It's gonna be very simple. Then I'll go over this in just a second. But let's just talk about the nursing process. On week 1, did we talk about this, any nursing process where we do an assessment, and did we talk about that? Did I talk about that? I get confused because I've got some classes going on. Okay, here we go. So let's talk about the nursing process, okay? First of all, the nursing process has to do with what does a nurse do? Have you ever thought about that? Like what? The nursing process has to do with, have you ever wondered what the nurse does? Apparently there was a congresswoman in some state or Washington State. What do they do all day? Play cards, right? Well, in some places that might be true. I'll be honest with you, there is downtime. Some people say, I'd rather work the night shift because, I'm a night person. But in all honesty, there is no time to play cards. Everybody should always be doing something. And the moment when there's too much downtime, a proper ran hospital should say, okay, each nurse started with 4 patients, half of them are down to 2. So let's go ahead and let somebody go home. And by the way of staffing, they have a list, or they have a list on so they put them all together, crunch them all together. You can go home. It's your turn if you want to go home. So we're not playing cards, guys. We're moving things along, okay? So I said that to say, well, what does the nurse do all day? And in order for you to function as the nurse, you got to think like the nurse, okay? So right here, we're giving you a lot of information. Your Professor Jenny, your Professor Silva, here in this classroom here, a lot of information. As you can see, this is hands-on. Over there, it's a little bit more theory. You've got to pass your test. You've got to, you can't be here unless you pass. But let's talk about real life, real hands-on, what does the nurse do? So let's talk about the nursing process first of all, okay? So I want you to go ahead and write these titles here, okay? And first of all, what the nurse does is assess. And go ahead and leave 3, 4 lines in between. And after we assess the patient, we're going to plan. Okay? And after we've planned, we're going to do interventions. And then after that, we're going to evaluate whether what we did or not worked. Okay? So let's talk about the assessment. Okay? Remember, week 1, head to toe assessment. You went home, studied it. We came back. Did you guys do? We did do our assessment head to toe, right?
Yes.
We got through that. Okay. So actually, you did that last week.
Yes.
Right. That's why I'm not connecting. So here's the idea. When you go into your floor, you walk in at 7 o'clock. I'm just going to say in the context of 7 a.m. to 7 p.m. And your nurse is going to, the night nurse is like, come on, day shift, let's go, we got to go. They've been there all night. So let's get our report. You get a report on A bed, B bed, okay? 3A, 4C, and 5A. Those are your patients. You got 5 patients. You're going to go through the next half hour, you're going to go get a report. The nurse is going to give you a report. It's going to be admission diagnosis. It's going to be all sorts of information. Okay? And then after that, it's my job to go back and assess all my patients. So the assessment has to do with you getting to know the situation and the problem of the patient, get to know the demographics, 69-year-old male, English speaking only, or Spanish speaking only, or different language, culture, past medical history of, let's say, diabetes. You can write whatever you want. I'm not giving any information yet. Diabetes, hypertension, just demographics. And then why they were admitted to the hospital. That's your assessment, okay? Easy enough. I mean, that's just basic information. But then you have to figure out, or be told, or research, why did they come to the hospital? What kind of symptoms did they have? Let's say abdominal pain, right? Let's go with this NG tube insertion for today. Abdominal pain, abdominal distension, nausea, vomiting, okay? They come to the hospital, they get some exams done, KUB, indicates small bowel obstruction, CT scan of the abdomen, small bowel obstruction. Okay, we're on the same page, we have a diagnosis, okay? Based on that diagnosis, was created by who? A doctor, who what? Created this diagnosis out of thin air? No. Based on what? Assessment. So your scientific data, we have an x-ray, they went to school. Why do we need a diagnosis to begin with? A medical diagnosis? So that they know exactly how to treat, because based on evidence-based practice, the doctor knows small bowel obstruction is NPO, and you have to write this down, NPO, daily x-rays, IV fluids, pain control, nausea control, right? Ambulation to help this process, NG tube to wall suction, okay? The continuous wall suction. And that process in the first 24 hours, 36 hours, is gonna hopefully allow the patient to get better, okay? So when we're talking about, this is also kind of maybe known as ADPI, okay? I learned it a little bit more like this. It is pretty much the same thing. But we need this foundation to be able to do our care plan. So that's why I'm going this route. Okay. So we have the assessment, we have the symptoms, we have a medical diagnosis, we've assessed the abdomen, and what kind of abdomen are we gonna as the patient gonna present with? Distended. Bowel sounds are gonna be diminished, right? Because nothing is flowing. The peristalsis is, everything is not doing so well. Okay, so we've got abdominal distension, and remember the percussion? Ding, 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 ding. You're gonna hear that little drum sound. Air, distension, decreased bowel sounds, no bowel movement, and everything's coming up. Why? Because the patient continues to develop gastric products that are gonna need digestive juices, if I can just say it like that. That's why we throw in that NG tube to decompress the stomach, remove the air, remove the fluid, remove the secretions, remove the acidity that makes them sick. Okay, so that's our assessment. Okay, so we have a small bowel obstruction. Let's move on. When we have our small bowel obstruction diagnosis, we've assessed the patient, and we discovered everything that I just said, all their symptoms. Now we can start planning. Okay, I'm gonna go very quickly on this. What would our plan be for this patient? NG tube insertion, NG tube suctioning, okay? And our plan is gonna be NPO. The plan is based on the doctor's orders. IV fluids, nausea control, Zofran, Reglan, okay? And then ambulate the patient. Why? We don't want the patient stuck in bed. What happens when there's no ambulation? Anybody ever have a little pain control vacation? You have pain, you feel sick, right? You get a flu. You don't feel good. You have a headache. What do? Take your medicine and go to sleep, right? But what happens when you're doing that in the course of a hospital for 24, 48, 72 hours and you don't move? Muscle atrophy. You feel sick. And guess what happens to the motility of your digestive system? There's no movement. Okay? So if we can get the patient ambulating, chances are that we're going to do, so the plan would be that the patient is going to ambulate. The patient will be NPO, okay? The patient will be given medications. When we plan, then we have our interventions, okay? Now we can have our interventions, and that is from your textbook, it's from your physiology, I'm sorry, not your pathophysiology, your NANDA book, okay? I recommend Sparks and Taylor. No, the school doesn't offer to you, but Sparks and Taylor wrote a very good nursing diagnosis workbook. It comes in pocket size. You can take that to clinical with you, and it comes in regular size. $15 on Amazon, and you'll have it for 2 years, and it'll be great for you. Okay. Now we can do our interventions. Yes. The authors are Sparks and Taylor, and then it's a nursing diagnosis handbook or something like that. Okay. So therefore, now we can do our interventions, and now we can plan, and now we can carry out. Up to here, I was just thinking about being a nurse. Well, this is nursing, but now I'm going to be the nurse, hands-on. I'm going to provide IV fluids. We're going to give them an IV fluid bolus. We're going to give them the whole bag per doctor's orders, and then we're going to run it at 75 cc's an hour, 100, 125, 150 cc's an hour, depending on the size of the patient, okay? And to make sure that they don't have any sort of heart failure, anything that's going to overload the patient with fluid. And then we're going to provide Zofran or Reglan every 4 to 6 hours as ordered by the doctor, okay? And we're going to ambulate the patient. We're doing the work, okay? And that's what we do as the interventions. The evaluation, we're going to evaluate, it's basically what I did it work or not? So it's going to be in, if you want to write this part down, it's going to be in 3 aspects. Goal met, goal not met, or goal what? Accomplished. Partially met. Goal met, period. Goal not met. Goal partially met. Okay. I'm going to show you how to write a goal when we get to nursing diagnosis. Okay? All right. So there you go with your, basically what I call the nursing process. Okay? Very simple. That's what we do. Okay? All right. We're going to go to the nursing care plan, and I'm going to incorporate this nursing diagnosis. You ready? This is going to save your instructor 2 hours next week. Please save me 2 hours next week by understanding what I'm about to tell you. Okay, this is what we use here. Let me make this a little bigger for you. Bring a blank copy of this next week, please. At the top is basically your student name, your instructor, the patient initials. Guys, please do not use real names on these patients. We can get in big trouble. That's a HIPAA violation. Okay? And remember, this is a pass, no pass class. Okay? Even though you want to score your grade to kind of allow you to know where you're at, with the skills that we provide you, the information of. Okay? But please, that's one of the things that can really get us in big trouble. Okay? One time, about a year and a half ago, a student brought back a whole chart of the patient. They copied it all. The official rule is you're not allowed to copy anything from the hospital, the nursing home, and bring it with you. It has patients' names, it has doctors' names, and you're not supposed to do that, so don't do that. Okay? Get all your information there quickly. But somebody brought a chart, and they were sitting on the front row just like this, and the professor said, "Hey, what's that?" "Oh, this is the chart from the hospital." Whole name on it. So you know, it was a sticky situation, and we had to take care of it. The school took care of it. Almost lost the site. So don't do anything like that. And every school's been guilty of that as well. So be careful. Patient's initials only. Code status. It's going to be two answers: DNR or full code. DNR or full code. It cannot be both. Full code means we will do everything possible, including chest compressions, CPR, and mechanical ventilation to keep the patient alive. Heroic measures. Okay, so you need to understand whether your patient is DNR or if they are full code. DNR means do not resuscitate. Do not resuscitate. If you find the patient and they are not breathing, they're cooled to the touch, you check the vital signs, there's no heart rate, there's no blood pressure, there's no oxygenation on the SAT probe, you know that something is wrong, right? You've got to do what next?
Check the code.
Check what?
Check the code.
Check the code status. So either should be on their wrist. If it's DNR, they're going to have a wristband. Should have a wristband. Or have the chart right there with you and check it. Really quick, call for help, do whatever you need to do. If it says DNR, you do not start CPR. You call your team, do a further assessment. You need someone else to check it out. You're going to call the house supervisor. I'm speaking in the terms of hospital life. Call the house supervisor, call the charge nurse. Keep trying to check the vital signs. Keep trying to check. And after about 2 minutes of this, you should know whether the patient is alive or not. Okay? If the patient is full code, you're going to start CPR and you're going to scream for help. Okay? So that you can get help, and the code team comes in, code blue to room 501. And here they come. And let those specialists do what they do. You start the CPR, but the code team will come in, which essentially is basically the ER doctor, EMTs that work in the ER, or any other RN, anybody, all hands on deck, CPR, start more lines, start more IV fluids, get out that epinephrine, get out that crash cart, okay, epinephrine, whatever it takes, and start getting the patient all coded up. Okay, code the patient and do what you need to do. They are a full code patient, so that's what goes here. DNR, let me explain a little bit of something. Patient is a hospice patient. Any medics here or EMTs that have driven in ambulances? Okay, so you pick up a patient and the patient's on hospice and they're DNR, you see it there, but the patient says, I want him to go to the hospital. What do you do if you're out there on the street with an ambulance? You bring him to the hospital. The family can revoke hospice whenever they want. Don't ever let some hospice person scare you. Oh, the patient can't go to the hospital, they're on hospice. Well, the family wants them to go, so they're gonna go. They've just revoked hospice. Drop the mic. Okay? Because the thing is, they bill on a daily basis. I worked for hospice for 6 years. They bill on a daily basis. The moment they don't bill, the patient goes to the hospital, they can't bill. So that's why that's their money, okay? And they want to be able to handle everything at home. Patient gets to your hospital. Patient fell out of bed. They're on hospice, and it's evident that they broke their leg, broke their hip, but they're DNR, and they're suffering. And their blood pressure is going down because now they're bleeding internally. And their leg is not getting any circulation. But you know that you have the hospice contract right there, and it says DNR. Do not go to the hospital, call the hospice agency. You're the RN. Doctor's busy. What do? You take care of the patient and take care of the patient. IV, blood work, oxygenation, vital signs, EKG. And then the doctor, what's going on? Patient's on hospice and they're DNR, but it looks like they fell out of bed and broke their leg. Okay, let's get an x-ray. Let's get some pain control. Let's take care of it. Okay, and hospice agencies have called my ER. This patient's on hospice. We just want you to know. We know that our nurse was there. The ambulance took them. They're on hospice. Well, not anymore because now they're in the hospital. That's how that works. Okay, so code status is DNR. Or, full code, allergies, put everything down. That includes medicine, products, plastic, latex, fruit, kiwi, frijoles, anything that they're allergic to. You're gonna put it right there, and people can have many. Okay? All right. To the top right, the date of that date. Your course is gonna be your course, unit and room. Be careful with that. I mean, don't get too descriptive. Okay, but you can put Highland Park, 1980, you know, stuff like that. Date, patient's date of birth, not yours. Patient's date of birth, height and weight. And let me give you a little secret and put a little cloud on your notes. Find the face sheet of the patient. Find the face sheet of the patient. Because when you find the face sheet of the patient, it's gonna have a lot of this stuff on it. Okay? You won't have to search too far. That'll have their code status. It'll have their past medical history, which I will get to. It'll have their height and weight. It'll have their diet. It'll have the name of their doctor, the name of their family. So find the face sheet. Okay? All right, so let's get into our top line right here. Can you guys see that okay? Or do I need to go a little bigger? There we go. Temperature. Each time you go to the patient, so what I hope happens is you're going to be introduced to this information on day one. In your first 4 hours of being there, you're going to be helping the CNAs, you're going to be helping the nurses, you're going to get this patient cleaned up, get them ready for the day, checking some vital signs. And I want you, and you'll do that for several people and go from room to room with your staff member and just go help everybody out. I want you to be at that moment looking for the patient that you just kind of feel like, I want to do my report on this person. And find that person. And remember, two students cannot work on the same patient as far as the care plan. You will work together as a team, but say, I call it, this guy's mine, okay? So do that, vital signs. All right, here's where it gets fun, because up till now it's been kind of just not fun. And I know you guys had lunch, and everybody's actually looking pretty good right now, so. All right. History of present illness. And then look at history of present illness right here. But down here, we see relevant, where is it? Past medical history. Did they change this on us? Okay. History of present illness and past medical and surgical history. What's the difference?
That's the current illness that they have.
So let me go to B. Past medical history can include diabetes, hypertension, small bowel obstruction, right? Partial amputation of the right foot, hypothyroidism, okay? We're talking about nursing 101, nursing home type patients. Of the things I just mentioned, those will not be reasons why the patient is living there. Let me say that again. Of the hypertension, diabetes, small bowel obstruction in the past, partial amputation, those reasons are not enough for the patient to go live there. Okay? I'm 48. I know you're amazed. If I go to Highland Park or if I go to Waterman Convalescent right now and I say, hey, my name is David and I wanna live here. They're gonna be like, excuse me? Yes, I wanna live here. Can I go live there? Well, they're gonna first say, well, do you have Medi-Cal? Do you have Medicare? No? Do you have disability insurance that covers your room and board in case you were having a chronic illness which you're not gonna recover from? In other words, like a hospice type diagnosis. No, I'm pretty healthy, okay? So why do you wanna come live here? I wanna just live here, I like bed, I wanna interact. Can I go live there? No, because these licensed facilities are licensed to only admit patients that qualify or have a qualifying admitting diagnosis. So that's what's gonna go here. The history of present illness, including admission diagnosis. That is super important. What's the admitting diagnosis? And if you're with me, and if I have you for every single class for the time that you're here, I'm gonna ask you in the hallway, what's the admitting diagnosis? Why are they here? So usually in these places where we're gonna go to are gonna be diagnoses like what? Dementia, Alzheimer's, failure to thrive, CVA, which is what? A stroke. What is their reason for being in the nursing home? That's the answer. And it should be 1 or 2, maybe 3. Well, they got high blood pressure. That's past history. Well, they got diabetes. That's past history. The patient might not have any diabetes or high blood pressure, but they've got dementia and Alzheimer's. Okay, have you seen them? They look very neat. They're always wearing their slacks, their shirt with their walker, and they're just kind of walking like this. That Alzheimer's, there's a name for that. Okay, a shuffling gait. Very square. Okay, so mask-like appearance to the face. That's why they're there, because Grandpa Joe can no longer live at home because he's wandering around. He's losing weight, a certain amount of weight when he's assessed. He's having this Thrive situation where he cannot eat, and he's just losing weight, losing muscle, and he's wandering. And his mental status is not controlled anymore. That's the diagnosis for Grandpa Joe. Okay? So just remember that. Now, I'm going to go with how I would like my class to do it, and Professor Jenny can do it however she wants, and your other instructor can choose however they want to do it. I'm just going to give you the basic tools and how I would want it done. When you write down this first diagnosis, let's say it's dementia, I want you to write dementia, okay? And then I want you to write, let me go back to my word page. Let's just say, so it's basically going to go like this. And then there's your definition, period. Okay, I know I wrote all that. Dementia, dash, space, the definition. The definition has to come from your pathophysiology book. Okay, so find it. Don't Google it. Don't Wikipedia it. Okay, and then a period. 2 to 3 to 4 lines. No quotations. This is in your own words. Okay. Define it for me. The same book, you're also going to define the second diagnosis. And what if it says CVA, which is cerebral vascular accident? Same thing. Okay? It's going to start off with some sort of hemorrhage, of the this and that. So please go ahead and give me the full definition of that. Okay? Any questions up to this part? It's going to be 1 or 2 or 3 diagnoses. These are the admitting diagnoses. I can't get into the nursing home because, well, sir, do you know that if you don't have any insurance, and this is true, it's about $6,000 to live in a nursing home, cash, if you don't have the money. I mean, if you don't have the insurance, or the Medi-Cal, or the Medicare with benefits into a nursing home. Well, what if I say, I have the money? I don't have the money, by the way. But I want to live here. I have the money. I want to live here. I can't, because why? I don't have the facilities licensed to take patients who have those diagnoses. So please keep that in mind. Your past medical history is going to be, and your instructor should show you the list and help you out with this part. We're going to be standing at the counter in the afternoon next Monday after lunch, and we're going to be going through this for a good 2-3 hours, getting all your information while at the same time helping out taking care of patients. Okay? All right. So we have our admitting diagnosis, our past medical history. Let's go here. Relevant diagnostic procedures. Okay, this is what you need. All your labs, but they live in a nursing home, they might not have labs. Let's say 6 months to 12, let's go back 6 months to a year. Anything, so these people still get labs done. Or what if, Jenny Sue over here, 88-year-old female, had a urinary tract infection. The lab came over, drew her blood, took her urine, and sent it off. You will find these are all old school charts. They open up, they have plastic tabs, and you're gonna find the tab that says labs. That's where you're gonna find that. Yes, Will.
You're 10%.
Okay. All right, so you're gonna just basically do the lab, look at the labs, and then you're gonna write them in right here. That also includes x-rays. It includes blood cultures. It also includes any, x-rays, blood cultures, urine cultures. These are just basically anything that you can find, from the last 6 months to a year. And you're gonna put them down. Maybe they went to the hospital, they had some x-rays done. Maybe they went to the hospital and were admitted. And that's pretty, pretty standard for a lot of these people. I apologize, because right here it says lab tests, right? So vice versa. So relevant procedures, this includes relevant diagnostic procedures and surgeries, but we also have pertinent lab tests. So the labs are gonna go right here, and the diagnostic procedures might be interventional radiology, which really doesn't make a lot of sense right now, I know, but that's gonna be like under fluoroscopy at an MRI center or CAT scan center. But just take a look. So this is more like exams that were like in a hospital of some type. And labs are gonna be right here. Deal? All right, and as you continue to type into this, the whole template's gonna open up. Yes?
For the relevant diagnostic procedures, is that still within the last 6 months?
Yeah, yes. Good question. Yes, Winnie?
For the relevant diagnostic, is that only for the diagnostic test, while the blood and the UA in the lab?
So the UA, and you said something else before that. Stool, that to me is going to be more pertinent lab tests. That's a lab test. A diagnostic procedure for in surgeries. Also, you can also include the surgeries if they had a surgery, and all these guys are going to have surgeries of some type. Okay, gallbladder or a mastectomy, anything like that. Anything else for right now? Any questions? We're moving quick because we have to continue next door. All right, now we get to our Erickson's right here. Erickson's developmental stage. Ready? This is two things, and this does require APA citation. Look up your old psychology book, okay? And remember, APA format means within 5 years, okay? The patient is 85 years old. They fall under a category of what? Remember, stagnation versus generativity? Does that sound familiar? What's another one? I know, it's so long ago.
Like role identity versus something.
Yeah, role identity versus, generativity versus stagnation. There's several stages, right? So based on the patient's age, you're gonna find that you're gonna find that Erickson's stage. So you go into basically say this, the patient is 85 years old and falls under the category of Erickson's stage of generativity versus stagnation, period. Then define it in 2 sentences. This means that the patient, and it might say something like, towards the end of life, looks back upon their life and realizes whether they did or did not accomplish what they set out to do, and were a part of society, and they've given back to society. Now they are focusing more on family, grandchildren, things like that. In other words, they were either a success or they weren't a success in life, and they're going back in their memory, and that's where they live at now. Period. Next paragraph. Remember I said there was 2 parts? The next part is going to be the patient is 85 years old once again, and patient, you're going to agree with Erickson's or not. They're not hitting the mark. The patient falls under, however, they feel that their life has many sorts of regrets and failures as described by the patient. Let's just say, patient lost his family many years ago due to a gambling addiction or something like that. Okay, something to that effect. Do you agree or do you not agree? So it's basically the definition of Erickson's and then your own statement on how this correlates with the patient. Were you going to ask a question over there, Amber? Okay. So it's 2 statements. You agree or you don't agree. What this is not is a personal opinion. Okay? I don't believe the patient, you know, and a student one time did that. You know, the patient did not have family or children ever, so I don't believe that they've been an asset to society. That's, or, you know, that's what they said. And I said, you can't. So why is this important? Because when I have a little bit of a background regarding the patient, and I kind of know where they're coming from, guess what I do? This guy's been homeless for 10 years, doesn't have anything. I'm gonna probably give him a little bit more compassion and a little bit more help. They might need a little bit more, okay? This guy's been on the streets forever, and now he's really sick. I'm the one who he has. That's all, he's all I got. I mean, I'm all he has, and well, in that moment, he's all I got right now too, right? So I'm gonna do my very best because I'm working with him for another 12 hours. So I'm gonna do my best to take care of him. When you know the inside story of a person without getting too personal, it's gonna give you a little bit, and that's where the heart comes in. And this is where you can do a much better job. You know how to talk to them. You know what they're going through. Okay? So if you've ever been in a patient in the hospital bed, isn't it better when you have a little bit more of a, even if it's just for 10 hours, a little bit more of a connection? It's gonna help you to trust this nurse and understand what they're going through. And they certainly know what I'm going through here. I'm all sick. I'm all laid up in this hospital bed. All right, to the right is that socioeconomic, cultural, spiritual orientation. This is basically a one small paragraph. Patient is 85 years old, married for 52 years, 6 kids, 20 grandchildren. And this is all going to involve an interview of the patient. What? We're going to talk to the patient? Oh, you are going to sit down, talk to them, become friends. Okay? Maybe they can co-sign your loan or something? No, just kidding. Just kidding. You know, I'm just kidding. Don't ever do that to a patient. Don't ever date at wherever you work either, guys. I don't know. I just wanted to throw that out there. Okay? All right. So, okay, so socioeconomic is going to be that, exactly what I just said. I don't like the word economic. It doesn't matter to me who they are, where they come from, whether they own Kmart or Walmart or whatever. Doesn't matter to me. We treat everybody the same. Spiritual orientation, you may add some things there if you want to. Patient adheres to a Christian religion, but they no longer attend church. Patient is spiritual but not religious. Patient was a minister of this or that, and this is important to them. Whatever it may be, patient is atheist, and they couldn't care less about God. I mean, well, you're not going to say it like that, right? But patient is atheist and does not ascribe to any sort of religious whatever. Okay? So that's what goes there. All right, potential health deviations and interprofessional consult. Let's go with potential health deviations. With all this that's said in the directions are right here, guys. I don't know what to do. It's right here. At risk for. At risk for. Are you ready? It could not be any more easier than how I'm going to talk about this or say this. Okay? We can go ahead and shut it down. Thanks. Okay, thanks. Potential health deviations. Okay, let's talk about the at-risk statements. Right here, you're going to need to develop 2. And this is where it's finally going to get even more funner and funner. All right? Okay. Remember, nursing diagnosis is different from at-risk statements. It all falls under NANDA. What is NANDA? Nursing diagnosis. It's the North American Nursing Diagnosis Association. Okay? NANDA. I don't know who they are. I don't know where they came from. I don't know where they're based. I don't know who's a part of this, but it's just NANDA. It's been there for many, many years, and it'll be there forever. There's a nanda.com out there. Don't ever use it. It's just very generic. It's too superficial. They don't go very deep into it. They just, so don't bother with that. But when you have NANDA, you have an at-risk statement, but that is not the nursing diagnosis. That is not the nursing diagnosis. That's going to be more clear in just a second. But when we talk about at-risk statements, so we're going to go to the nursing home, Patients are going to be bedbound. We've talked about bed positioning. We've talked about rails. Okay? We've talked about ambulation. Right? We've talked about those crutches, and we've talked about all sorts of things. When you go into a nursing home, what is the kind of like, I can think about 7 things right now. What is the worst possible thing that can happen to it? Let's just say little old Granny Sue, who's in bed and been living at this facility for 10 years. What are the biggest at-risk things that she can be going through? By the way, her diagnosis is dementia.
Abuse.
Risk for abuse? Well, no. That's if somebody harms her. But no, I'm just talking about her own personal self and her physical condition. Falls, okay. All right, let's break it down. At risk for falls. Okay. All right, what else? Pressure injury.
Injuries.
Okay. At risk for skin, we're gonna call it like this, skin breakdown. What else? And that's where the skin opens up when we have wounds. Okay. We'll break these down. What else? Atrophy has to do with like muscles that are no longer working. How about this one? How about physical immobility? Good. What else can they be at risk for?
Deficits.
Neurological deterioration? Okay, all right.
Further.
Risk of further neurological? Okay. I don't have the words for that, but as far as how we can put it in a at risk for, they're already mentally deteriorating. Okay, so I hear what you're saying, but what you're saying is going to connect with something else later on. Just watch. So what else?
Don't they go missing, like if they can walk?
Can they go missing?
They can walk if they're ambulatory.
Well, that's not necessarily yes and no. They can go missing,
Yeah.
but it's not really a nursing diagnosis, or it doesn't fall under this.
GI blockage.
Okay. That can be any patient, but you're onto something. I'll get back to that. Somebody else says something else over there. Jen. Depression. So there's a at-risk hopelessness. Good. How about the patient is not eating very much? So how, and not drinking much. How about at risk for dehydration?
Malnutrition.
Okay. And also along with that, at risk for, I think it's nutritional deficit. Okay. 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 Remember we talked. Did you guys talk about diets and things like that? Well, you will. So, because they're going to do an exercise over here next door with you guys. The patient cannot chew very well. Okay. Choking hazard. How about aspiration? Okay. I'm giving you the answers. So next week you're gonna be like, that's it. And I'm gonna save you an hour right here of your time at home while you're putting this all together. If you just listen to what I'm gonna say, I'm gonna save you many, many, many hours for the next year and a half that you're here at this program. Okay. So there's our risk statement. So the instructions is right here, potential health deviations, predisposing and related factors, and then the interventions to assess or prevent the potential health deviations. So it starts off with at risk for, it says here nursing diagnosis, but it's part of a nursing diagnosis thought process, but it's the at risk statement. So we're gonna go ahead and go with our dementia patient, and I'm going to do this one. At risk for aspiration related to, she has dementia. And who said the neurological deficiencies? You did, right? Okay, what's your name again? Hopefully. So because she's confused, and would this risk for aspiration be connected to the inability to eat and chew and swallow properly? Yes. Dementia patients they can't, eventually this starts going away. So if I can say, what is this at risk of aspiration due to? At risk for choking. We don't want to use the word choking. If I'm gonna blame it, okay, dysphagia. Okay, so let's go with that. At risk for aspiration related to dysphagia, which is what?
Difficulty swallowing.
Inability to swallow properly. Okay. And cognitive disorder. That's it. That's it. The at-risk statement does not have as evidenced by, and that'll make more sense in about 5 minutes, okay? The at-risk statement does not have as evidenced by. But let me give you a secret. The as evidenced by is this, is the related to. It'll make more sense, I guarantee you. At risk for, okay, how about this one? At risk for hopelessness related to, what's the evidence? What are they doing? What are they saying? Sleeping 16 hours a day. How about, or related to, verbal statements of what? Wanting to die. Honey, I just want to die. Oh, it's okay, Sue, you'll be fine. You're okay. Speaking a little southern accent, you're okay, honey. That always makes them feel better. Okay? So there's your risk statement related to what? What are they manifesting? What can you hear, smell? What can you palpate? What can you see with your own eyes and listen to? Physical immobility. At risk for physical immobility related to, somebody said muscle atrophy, right? So how can we say that? Weakness of all extremities and inability to stand longer than 30 seconds. Did you see what I just kind of did? It's right here. The related to is actually evidence. It's what I see. It's what I assess. Okay, let's do another one. At risk for falls related to, what's the risk? I mean, why would they be falling? Generalized weakness, muscle atrophy, confusion. What is it? It can be all of those. Okay, so that we can pick one. At risk for falls related to generalized weakness. Or if you wanted to say, cognitive deficiency. Or how about at risk for falls related to, this cognitive deficiency can also be generalized confusion or increased confusion. Okay. At risk for skin breakdown related to, okay, why would the patient have skin breakdown? How did those stage 4 wounds that are right behind this wall here, how did those happen? Just in 1 or 2 days?
No.
It was months of sitting in their stool or their urine and their inability to what? You just said it. Get out of bed and go to the bathroom, clean themselves. Okay, so a lot of things happen. At risk for skin breakdown related to what?
Incontinence.
Okay, incontinence, I'm gonna write them all out. Incontinence or patient's, or I was gonna say patient's inability to empty to the bathroom, but we can say related to physical immobility. I'm using abbreviations just at the same time. Okay, so but you don't use abbreviations. Okay. There you go. There's your at-risk statement.
So when we're writing this out, we say at risk for in every single.
Yes, that's the NANDA, and now let me introduce to you the why. It's a format. You don't change the format. The at-risk for is the format. You don't change them. You don't, please don't do this. Here it is. Patient is bedbound, therefore is at risk for skin breakdown. Don't do that. Don't change it. Don't get NANDA mad at you, okay? You don't, it doesn't change. It's a format. Don't mess with the format. At risk for physical immobility, okay? At risk for hopelessness related to. Can we move on now to the cool stuff?
Yes.
So your assignment says at-risk statement, but then it also says interventions. The thing, oh, what I don't see here is how many interventions. Always ask, well, how many interventions do you want? So this one says 4 right here. So on this one right here, this potential health deviations you're at risk for, it also now wants you to create, I'm gonna say 4 interventions, okay? You have 2 risk statements, but on each statement, you have 4 interventions. All right? You're gonna get these from your book, your nursing diagnosis book, or your patho book. Okay, so let's go ahead and create this at risk for aspiration. And what I want you to do, and of course your instructor is gonna be saying, I want you to do it like this. I want 4 bullets, okay? Now, this is gonna come from the book, but I'm just gonna think at the top of my head here, and you guys too, because this is all pretty much, some of it's very common sense. At risk for aspiration, related to dysphagia, which means they have an inability to swallow. So therefore, what is my intervention gonna be when I'm talking in the context of serving patient food?
First out of the bed.
Okay? Elevate bed to semi
Fowler.
or high Fowler's position for feeding. Good. What's next? Let me give you one. Serve food in small, bite-sized portions. Okay, what else? What else? Okay, how about allow time for patient to chew and swallow food? How about this one? Because they have a risk for aspiration and they have dysphagia. How about this one? Before you give them any food, consult MD and order a speech pathology assessment. These are master's trained speech pathologists. In other words, I could have said, order a swallow eval. Swallow eval would be much more, but these speech pathologists come into your unit, they come with a little bag of little stuff, they have these iced little sticks, whatever, okay, swallow, okay, chew. And they do all these tricks inside the patient's mouth to see what they're able to do, and then they give them ice chips to see if they can swallow the ice chips. Okay, somebody had a question back over there. Cassie, you had a question? Okay, sure. Just let me know, guys. Just interrupt me at will. I'm married, so I'm used to it. I love coming to work. I can make all sorts of wife jokes. All right. So there you go. Any other questions? What else can we add to this? We're talking about aspiration.
Maybe just like always monitor the patient during meal times.
Okay.
There's someone that keep it stopped.
Good. Watch your patient for safety during mealtime. Good. All right, we can keep going on and on and on. let's do this one. At risk for physical immobility related to weakness, generalized, or inability to stand longer than, okay. So what's gonna be our interventions for this patient?
Perform range of motion.
Say that again?
Perform range of motion.
Okay, perform,
Exercises.
Range of motion.
strengthening exercises. Okay. Or educate on, or including range of motion exercise. Somebody else said something. Okay. How about educate patient on use of call light? Okay. When wanting to get up. Okay. Now what else can we do?
Into assisted devices.
Ambulate patient with gait belt. It's the use of the gait belt. What else? Somebody's gonna say something.
Do the using of assisted devices.
Oh, yeah. Okay. Use walker cane for ambulation. What else can we do? Refer to physical therapy. These are just interventions. Okay.
Something like that, would you be more concerned with the gross motor skills and not really occupational therapy?
So there is occupational therapy a lot of times, and they're basically working on these fine, and then, but this, as far as what we're talking about here, the ambulation, we're basically, yes, large muscle movement, and just getting from here to there, getting from their wheelchair, standing up, turning themselves, and getting back into bed. Yes, you're definitely, when we're talking about physical mobility, we're definitely gonna be more concerned about the patient falling, things like that. Someone else can deal with the fine motor skills. Yes, absolutely. We're doing this for the safety of the patient. Any questions on that?
One question.
Yes.
One question. Is the all caps part of Nano too, or is it just something that you're?
No, I was just doing it just for the
Okay.
size. No, this is not all caps, don't like beat us up, don't be, isn't it meant to be expressive if it's all caps? Great question. Your title though is gonna be, you're at risk, so it's gonna look more like this. I'll show you. It's gonna be like this. Okay, so that's how it's gonna look. This right here is the first letters capitalized. Thanks, that's a great question. Okay, so we wanna get back to our nursing care plan. Right here, interprofessional consults, discharge referrals, current orders, including diet, tests, and treatments, with a rationale and APA citations. Okay, that part that says with rationale with APA citations, cross that out. To me, this basically means, and Professor Chong might have a whole different view of this box right here, but this is what it means to me. I was a case manager for about 6-7 months, and as you can see, it probably was a very good choice. Wasn't really mine. I wanted to be behind a desk and have weekends off and all that business, and I only lasted like 7 months because the lifestyle was just a lot different, and I didn't enjoy it that much. But my case manager side of me wants to know, well, if the patient is in the hospital, have they, they were here for, they fell and broke their hip, have they had a physical therapy consult? Where is it? Okay, are they gonna go to a nursing home after this for 2 weeks? Because they can't stay here in the hospital. So we need a consult from the nursing home to come and see who's gonna take this patient. The patient is gonna need a cast, right? We need orthopedic services to come over here and do some sort of crutches or something. So what I mean by that is this interprofessional consult, and you might want to write this down, any other medical professional or service that comes and does an assessment on the patient. Okay, any other medical professional or service provided to the patient to improve their care. Okay, so let me write this down. Dietary consult. The patient has some kidney problems. Who are they going to bring in? The medical doctor is just more like a family practitioner. They're not trained to deal with these kidneys. Anybody here ever go to a doctor, they say, we're going to send you to some specialists, and they send you all over the world for, you're going to do your left toe over here, and you're going to do your kidney over here, and you're going to do your eyes over here. Okay, or if you're part of Kaiser, okay, well, everything's in this building, you're just going to go to 10 different places that way, you know. And so that's what they mean by consults. One time I had chest pain it was about 8 years ago, and it was right here, and it scared me. I was at work, and it scared me. It like crushed me. It didn't crush my heart. It was just something, you know. So I got scared, and I was 10 minutes from, you know, my shift ending. I went home, and something really scared me. Like, so I went to my doctor from Fontana. I went all the way to Claremont, and they said, okay, well, we'll give you a referral. And yeah, 2 weeks later, I showed up, and I went to a heart doctor. I went to another place for an x-ray. I went to another place for an ultrasound of the heart. It's called an echocardiogram. Yeah, echocardiogram. And then after all that, I came back and I did a treadmill test. I went all over the place. If I would have just gone to the ER, they would have tested me for everything and made me go home by the next day, right? Or not even admit me and say, what happened was I was taking these very cheap vitamins. They were generic and they were real chalky. So my stomach was doing some digestive things. So I guess it was just that. So that's all it was. But this is anybody who, sorry guys, I have a lot of stories. But I'll try to stick with the plan here. Interprofessional consults is anybody who, so that could be dietary, physical therapy, occupational therapy, renal physician. Okay, if the patient is having more confusion, what kind of referral are they going to get for that? Neuro. Okay. What does not go here is the actual diet that the patient is on. If they say pureed diet, it doesn't go here. For some reason, the last 2 terms, my students have all been doing that. All you have to do is write down dietary consult. Give me the date. Okay, so dietary consult, May 2019.
Don't include diet tests and treatment.
So that's why they were doing that. So, okay, orders include diet, tests, treatments. So, yeah, thank you for that. Cross out diet, because your diet is actually, you might end up somewhere else in this document. But that to me is not a consult. That's the doctor giving you, saying this patient needs a pureed diet. But if they got speech pathology, then it goes here. All right. All right.
Does the test and treatment stay though in that box? Just take out diet?
Yes. Test and treatment. You notice if they had chest pain, they probably had an echocardiogram, or just put cardiac consult.
Okay.
So really, actually, it might not even need to go there, but you can talk about it with your instructor. All right, 2 things right here. This, oh, they changed it. Okay, good. So this stands alone. This is the map. Just don't worry about what's down here. Just worry about this, okay? This is really my favorite thing to talk about, because we're going to talk about now nursing diagnosis, okay? As you see here, nursing diagnosis related to blank as evidenced by. Please take note, it's evidenced, ED, evidenced by signs and symptoms, what you see, hear, feel, touch. So let me break this down again. This is your NANDA diagnosis related to contributing factors. This right here, if you want to write this down in a little cloud, this is pretty much the medical diagnosis without saying it's the medical diagnosis. Once again, it's the medical diagnosis without actually saying that it's the medical diagnosis. So we have to use our nursing language, and I'll make that clear in just a second, as evidenced by signs and symptoms. Okay? So, right here on your document, now let's go ahead and do this. And here's the instructions, guys, and as you start writing it in right here in this box right here, it's going to open up the template. So let's talk about that NG tube. Why do we need an NG tube? What would be the diagnosis? Let's say your most typical small bowel obstruction. And what is that? There's nothing going down, and again, everything's coming up, so we need that tube in there to suction out all the junk, right? There you go. So if you want to go ahead and Google this, I'm sorry, I know you didn't pay money to Google anything, but to save time and so that you can see what I'm talking about, and if you want to make your own list, or maybe your professor gave you a list. Anybody have a list, an exhaustive list of all the diagnoses? Somebody, and if you don't have one, share it with, if you don't have one, ask for someone who has it. It'll save you some time. Again, we don't change NANDA. That's why I'm saying you can find it anywhere. We don't change it, we don't add to it. They add to it. This is a format. So let's talk about this. The nursing diagnosis, and we'll get back to this document. If I'm gonna use, if I have I already know the nursing diagnosis for NG tube insertion. A patient has a small bowel obstruction. It goes something like this. Are you ready? And I'm using all caps. Actually, I'll write it in the format it should be written. Okay. There's your NANDA diagnosis right there. Gastrointestinal motility, comma, dysfunctional. Ready? What's next? Related to. We're going to leave this blank for now. Okay. As evidenced by what are the symptoms and what do we know? Remember, objective data. That we know that a patient who has an NG tube, needs an NG tube, what were they presenting with? Nausea, vomiting. And I'm going to make this even more detailed. Vomiting for 2 days. What else are they presenting with? What does their abdomen look like? Distended abdomen with absent what? Vowel sounds. So I've got 1, 2, 3 items there. Not yet, because it's a pretty quick thing. So constipation is no bowel movement for 3 to 5 days. So they have had the vomiting for 2 days, but they still had a bowel movement. Usually it's diarrhea. What were you going to say about that? Tenderness upon palpation. How about abdominal pain? 8 out of 10. Is that all provable? Is that all objective data?
Yes.
Okay. No?
Well, subject from the patient, but for us, we go by that, right?
Well, I can see that she's vomiting. I can see that she has abdominal pain. I can hear that there are absent vowel sounds, so I don't hear them. I can see and palpate and touch a distended abdomen. Yes, Sam, Mark.
Is nausea objective?
I can see it. Okay. And this is for the purpose of me here, okay? If Professor Silva says that's fine. I'm just telling you, these are the facts. And this is what I see the patient doing here. Okay, so, and the most important one for me is this one, radiology. Okay, let me shoot this so we can see it all on one page. All right, our nursing, our NANDA, gastrointestinal motility, dysfunctional, related to blank, we're gonna get to this in a second, as evidenced by nausea, vomiting for 2 days, distended abdomen with absent bowel sounds, abdominal pain 8 out of 10, radiology demonstrating bowel obstruction. That's like 6 evidences by. I'm stretching it out a little bit, but I just want you to see what I'm looking for as an instructor. How does the student know that there is a bowel obstruction, or that we're going to use this gastrointestinal motility as a nursing diagnosis? Let me give you another secret. We've got to develop these nursing diagnoses in order to prioritize the care that we're providing the patient. Oh, but the patient has a history of falls. That's fine, but I need to save their life right now. Those are the risk things that might happen. That's not anything compared to me developing my nursing diagnosis. The doctor developed their diagnosis, which is small bowel obstruction, which is actually right here. But I have to create my own diagnosis in order for me to think like the nurse, and I can do like the nurse. That's why we create this, okay? So what goes in the middle? What was the secret? This is basically the medical diagnosis, but without saying small bowel obstruction. Get it? It's the medical diagnosis, it's the cause. What's the cause of this gastrointestinal dysfunctional motility? The obstruction. How do we say that without using the doctor's verbiage? Okay, someone said blocked, keep it coming, you're getting there.
No bowel movement.
So, no, well, that's more evidence though. What's the cause? The obstruction is the cause. So how do we say that in our terms? Okay, so we,
Intestinal blockage.
blockage, okay. The ladies down here in the front, intestinal blockage. We're gonna go with that and we're gonna clean this up. I just want you to get to thinking this way. Okay? How about, and I'm just gonna write them all in here. Digestive. How about obstruction? I'm not saying small bowel obstruction. I'm saying digestive obstruction. Do you get it? Did the light turn on right there?
Yes.
So basically, this whole related to, okay, is how we throw in this. It's the cause, guys. It's the cause. Okay, once you understand it's the cause, I just saved you another 12 hours combined over the next 12 months. You trying to figure out what goes there. It's the secret of it. If you can figure out what the cause is without using the medical diagnosis, then you have your related to. Okay? So that's gonna go right here. You'll need 2 of these. So this template's gonna open up. Professor Chong, I am saving you 2 hours of time next week by going through all of this. Okay, and Professor Schmidt, all your other future
Thank you so much.
121 or 211 or 481 students right here. Okay, so right here, planning. This is your goals. Okay? Now they're saying, again, people are saying, hashtag goals, or oh man, your goals. Goals. To me, it's goals. Okay, the goals have to have 4 elements. Ready? The goal has to start off with patient will. That's how it's got to start. Okay, without the quotations, but I'm just saying that the patient, so if we have, and I'll go through this in a second. That's your first. It has 4 elements. The goal has 4 elements. It must be a future tense statement, and it starts off with that. You do not add to it. You do not say, after doing the interventions, the patient will, no, it's patient will, that's it. Number 2, the goal has to be measurable. Okay? And I'll explain that in a second, and we're gonna come up with this. It must be realistic. And number 4, it must have, it must be time sensitive. What I like to call closeout time. All right. So if we have a small bowel obstruction, and I need about 10 more minutes, okay, guys? If we have a patient with an NG2, like next door, our goal is going to be patient will Now, what were his symptoms? Nausea, vomiting, pain. What else? Abdominal distension, obstruction, right? And
Absent bowel sounds.
absent bowel sounds. Okay, so let's pick, we can't pick all 6 of them, but what is the most important of all these things that we talked about right here? From here to here. If I'm the nurse and we walk into the room, they have an NG tube, they just got started with their treatment, they just were admitted, what do I want to accomplish next? You just put in the NG tube. Let's just say we were in those first 2 beds over there, right? And you're done. All right, sir. And what did you say? You lowered the bed 30 to 45 degrees. You walked out. But what happens after that?
Try to reduce pain.
Right. So what would be the most important thing?
Pain.
Right, Irving? The pain.
Right.
Okay. Okay, so we're going to choose that.
Okay.
What else would be more important? The nausea and vomiting to me is very important. Okay. Nutrition? No, because they can't eat. The treatment is NPO, pain control, nausea control. So the nutrition right now, yeah, it can be a factor, but they just got there. So let's go ahead and create our goal. Patient will, remember this was our nursing diagnosis? I'm gonna choose the pain and I'm gonna choose the nausea and vomiting too. Now, what my goal is, basically what this is what you hope to see in the next hour or 2 hours. Patient will verbalize pain of 3 out of 10 and have 0 episodes of vomiting. We'll stop there. So let's test it. Is it written in future tense? Yes or no?
Yes.
So I'll raise this up, sorry. And I'll increase the size here. Is it written in future tense? Yes.
Yes.
Patient will. Is it measurable?
Yes.
What's the measurability part?
3 out of 10.
3 out of 10 and 0 episodes of vomiting. Number 3, is this goal right here realistic? It is realistic because for me to go, so it's realistic right now. Okay, and now we're going to make this time sensitive. If you were that patient in room 1 and 2 receiving the NG tube, how long would it take for you to be happy if you were no longer vomiting and if your pain can go from 8 to 3? You'd be a happy camper. If the nurse and the doctor can fix me to this in how long? What's realistic? Hour? I'd be having like 3 minutes, but that's not realistic. So if I say 0 episodes of vomiting during the next 2 minutes, is that possible? Why not? Because the drug takes time to work. The NG tube takes time to work. The nausea medicine takes time to work. So if you say 1 hour, I'm pretty much right there with you. How about patient will verbalize pain 3 out of 10, 0 episodes of vomiting within the next 1 hour. You said 1 hour. Who said 5 hours? Jacqueline, we're gonna make you suffer for 5 hours. Somebody throw in an NG tube. We're all trained to do it. Okay. Actually, for me, it's probably knowing that how fast Dilaudid or morphine works and how fast Reglan and Zofran works. I'm gonna say maybe 30 minutes. And it's okay if you're under my watch for you to write it like that too. There we go. There's our goal. Hashtag goal right there. Patient will verbalize pain of 3 out of 10 and have 0% vomiting within the next time. Do you see what I did here? I created my nursing diagnosis for the purpose of what? Creating a plan. Oh, is that what we do? We don't play cards? No. We think and we create goals. Now that we have a goal, and that's gonna go, I'm sorry guys, this is very tedious, but we are gonna save your instructors, including me, a lot of time. From what I understand, the place we're going to, there's no place for us to meet. It's either outside or in the hallway. So that's why I'm spending some time with this. And your third professor, whoever they may be, will give me a text message and say, thank you. Okay, now we're going to create, right here it says prioritize independent and collaborative nursing interventions. It's just basically an intervention, all right? So if we're taking care of this patient, and you gotta save these notes because come next Monday night, you're gonna be like, what did they say? What goes here? So now we can do an intervention. And I'm sorry I'm taking a lot of time. Actually, I'm not sorry because it's gonna save you guys, because I don't think instructors teach this enough around here. Intervention. All right, we want 4, right? All right, we're gonna focus on pain. I'm gonna focus on pain and what else? Nausea, vomiting, right? Okay, our intervention now, let's talk about the pain. And you're gonna write it like this, and I know you don't know the lingo, but we're gonna provide, obviously, pain medication, right? Provide MD ordered pain medication. That's it. Whether it's IV or PO or transdermal or a PAP, I don't care. We're gonna provide pain medication, but it's MD ordered. Number 2, how else can we provide pain relief without providing meds? Remember we've talked about non-pharmacological interventions. What are they?
Turning down the lights.
Such as, okay, I'm just gonna paraphrase here. Lights, room temp, what else?
Make the patient comfortable.
But how?
Getting pillows.
Okay.
blankets,
What would it be called? There's a term for it when you're hugging a pillow.
Comfort measures.
Comfort measures. But this is the comfort measures. But that's why we said provide non-pharmacological. Okay, let's just put it right here. Comfort measures. Interventions, lights, room temperature. What else? Cool, damp, towels
towels.
overhead or abdomen, right? What else? Sure, why not? Warm blanket. So you can just keep going on and on and on and on and on and on. All right, what else? What's number 3 gonna be? Okay, we're gonna provide MD ordered, and it's called antiemetic
Yes.
meds. Okay, and what else can we do for that nausea and vomiting? Okay, NPO is the order.
IV.
Okay, there you go. IV fluids for hydration and nutrition. And that IV fluid is going to have salt and potassium and chloride and, okay. So there you go. And electrolytes. There you go. There's your interventions. Any questions on that? We're almost done.
Is NPO known in?
Make patient NPO or NPO status. Patient status NPO. However you want to write it. But basically means nothing by mouth. Okay. Because remember, we gotta focus on this and all the things that comes along with it. Okay. All right. So now we have our evaluation. Any questions on this? When we go to evaluation, remember when I said it was goal met, goal not met? Okay. So the patient, you did everything, and after 1 hour, the patient's pain is 3 out of 10. Goal met, period. And that's it for now. Goal met, period. Or goal not met, partially met. Goal met. Patient states pain 3 out of 10. After receiving pain and nausea medications 1 hour ago. All right? Goal not met. Patient verbalizes pain 6 out of 10. And 2 episodes of vomiting noted. Goal partially met. Patient verbalized pain 2 out of 10 for 20 minutes, but now states pain is 9 out of 10. So see how it's partially met?
Yeah.
They were controlled, but not for very long. So on these second two, when we say goal not met and goal partially met, what do? Hope and pray? Hope for change? You know? No. We're gonna see what else we can provide. We don't automatically call the doctor. If I gave them morphine, the order might be written out a certain way. For pain, 7 out of 10. But then there might be another morphine order, provide for pain 8 to 10 if first dose ineffective. Read the orders, okay? So it might say something like that. So then you can go ahead and provide that second dose of pain medication. You may have given Reglan, which is one type of nausea medication, but also on the list is also Zofran. Okay, so we try that route. We can go that route. Okay, if they're Latino, Dalon is Sprite. Dalon is Sprite. That's what I said. The Vicks is for the energy. All right, so we have to do whatever we can. So that's how you write that. So let's go back to our form. Is this boring or what?
I mean,
It's a lot of information, I know. But if we don't go through this, you guys be lost when you get that document. Yes.
Can you just switch back real quick?
Sure.
Thank you.
It's gonna say, guys, I'm not kidding you. When students come to 481 and they don't know this stuff, I have to start over again. And you guys are getting the information on week 4. Okay, so it's best you kind of figure this out. Can I switch now?
Yes.
All right, let's finish this doc up, then we'll get a break. The last part of this documentation is your medications. You will need your drug guide to do this. Again, your medications, and you will need your drug guide to do this. Okay? Your instructor, sometimes the patient will have collates and stool softeners and vitamins. Check with your instructor and say, do I need to include the stool softeners and the vitamins? Let them know, and if you're with me, it's gonna be a no. That's just too much, I call it busy work. I'm not a believer in busy work. So it's gonna be your medications, your blood pressure medications, your diabetes medications, things like that. Your class and purpose, it'll say right there, anti-emetic. It's gonna say pain, whatever. The route is gonna be PO, is it topical, is it IV? The frequency, Q 24 hours, QD, QOD, BID, TID. Mechanism of action, this right here basically means in 1 or 2 sentences, how does the medication work? Please do not become a chemist. Please do not cut and paste from your Davis drug guide software that you got in that CD. Okay, please don't do that. Read it and put it into your own words. So the mechanism of action, or how does it work? It provides dilation to the, I don't know, the loop of Henle, and it increases the urine, whatever. Side effects for my group, I only need 5 of the best side effects. How do you know they're the best side effects? They're usually highlighted. There's gonna be like 200 of them sometimes, so there'll be 30. I need 5 side effects right here. And then nursing considerations, I love this part. What specifically about this medication do you know, but the patient doesn't know, and you need to educate them on this? For example, there's a medication out there called Coumadin. It's a blood thinner for all sorts of diagnoses where blood thinning needs to be done. You guys don't know about clotting factors and vitamin K, right? You guys usually do, but at this point, I'm like, I don't know. So what are, if you're on Coumadin, and you will learn this, if you haven't learned already, or you'll learn it next term in pharmacology. By the way, I saw some former students who are now in pharmacology and intro to med surg, and it's tough. So have fun right now. Don't pay for it next week.
Can't wait.
Nursing considerations. Patient, and this is Coumadin. Instruct patient on avoiding leafy green vegetables, as it will mess up with the clotting factor. If the patient is on aspirin, it's a blood thinner, the nursing consideration will be educate the patient to refrain from using open-ended blades for shaving. Why? If they cut, they'll bleed. Okay. Benadryl. Notify patient that this will make them sleepy, and do not give this medication with any other type of opiate or any other type of medication that would cause drowsiness. Okay, so that's the nursing considerations. And this is short and brief, 1 or 2 sentences. Any questions on that? Any questions on this whole document?
How many nursing considerations did you say?
Just whatever it says there, the main one. It'll be 1, maybe 2. Okay. So once again, your main part, and where the bulk of your nursing care plan is going to be, the grades, whether this passes you or fails you, it's going to be right here in these nursing diagnoses. Once again, 2 nursing diagnoses. The planning it out, you only need 1 goal, which I went over. Your interventions need to be 4. Oh, and the rationale. That's why you kind of need the patho book. When you say provide MD ordered pain medications, the rationale is going to say something like, opiate pain medications are proven to be effective on the pain to receptors or whatever, you guys know the language, and therefore are considered, effective treatment for pain. You need to write that all down, and then here's your evaluation. If goal met, partially met, or not met, and the explanation. Deal? You need 2 of those. That's the hardest part of this whole thing. Anything? Any questions? Sorry it took a long time, but it's gonna be worth your time and effort. Now you have 2 hours to validate, sorry. All right, let's go ahead and take a 5-minute break, and then we'll